Welcome, welcome everybody. My name is Koya Cassandra Conteh. I am one of the leads of the London ACEs Hub Racial Justice Workgroup. My co-facilitator in the open conversation today, who is also one of the Racial Justice Working Group leads, is Mpume Mpofu.
Great, thank you, Koya. You're going to need to spend some more time practicing my name.
Sorry.
My name is Mpume Mpofu, and like Koya, I'm co-lead for the Racial Justice Working Group. And thank you, everyone, for joining us this evening, where once again we explore the issue of ACEs, adverse childhood experiences. That's what the London ACEs Hub exists for. And this evening we're looking at the issues of racial trauma. And we'll come to our special guests, but it's around making the link between racial trauma, health inequity, and in primary care as well as in medical education. That's what we would like to spend this evening looking at, and the broader issues of health provision within the NHS. That's what we're talking about. So once again, thank you for being here. And to Dr. Lucy Carter and Dr. Jonathon Tomlinson, welcome. We'll come to you in a minute. Let me just go through some housekeeping stuff. I'm pleased to say that we are on Zoom. Some of us that managed to sign up are on Zoom. So we're live streaming and recording the session. We're recording the session on Zoom, and we're live streaming on YouTube because the numbers exceeded what provision we had. So we're pleased to have everybody join us this evening. For purposes of progress, we've muted everyone. It's not anybody that's been selected out. It's just a case of making sure that everybody is muted and we can move forward. So when it comes to the time to ask questions and make comments, I'm going to specifically request that you put those in our chat as we go through. Put both questions and comments in there, because we will pick them up in the course of the process. So that's what we won't be. That's what we will be doing. The subject of ACEs, racism as an ACE, is a big topic. We will not be able to cover everything about it, but we're inviting you to express an interest on our website. That's going to be important to do, because we really want to take the whole subject forward somehow. So we won't be able to tackle everything in this evening session, but we're asking you to join them. Some of you might find the points that we're going to raise here upsetting. We recognize that the whole issue of race, racism, and racialization is a sensitive one. So we invite everyone present to exercise responsibility, be mindful of self, and care mutually for other people that are here. So please do take into account other people's views on it.
To start, we would like to observe a moment of silence and quiet contemplation in honor of those who have passed away due to COVID-19, serious youth and adult violence, as well as racism. So if we could take a moment now. Thank you. We would also like to take this opportunity to share and emphasize our London ACEs Hub 26th of September statement, a call to action to set the tone for our event today. The London ACEs Hub recognises and acknowledges that racism is an adverse childhood experience that causes deep-rooted traumas, denies the full humanity, and limits the opportunities to thrive for individuals and communities, resulting in a loss for society as a whole. We believe that there is an urgent and growing evidence that the individual, interrelational, and historical harm produced by racism constitutes a public health crisis in London. This crisis can be addressed and prevented by proactive awareness raising, empathy building, and cultural, systemic, and structural changes. We call for support and appeal to the London government, statutory and non-statutory organisations, parents and heads of homes, children and young people, educators, multidisciplinary professionals, survivors, and community advocates from all backgrounds to prevent and end the harmful consequences of racism. We have the power as individuals and a collective to make this happen, one committed step at a time, to end the adverse childhood experience of racism in London. Finally, let me invite one of our London ACEs Hub co-chairs, Tiane Graziottin, to introduce the London ACEs Hub briefly.
Well done. Thanks, Koya, and thanks for sharing our call to action. And I here invite everybody to join us in this journey, because it's so nice to have you all here. I'm extremely excited that we did a lot of work to get this webinar together, and I'm very, very immensely thankful to Mpume and Koya, our beautiful facilitators, Lucy and Jonathan, our wonderful speakers. Whenever I listen to the four of them here with me, I always learn, and I'm sure it will be the same with you today. And I want to say also big thanks to our lovely Roger Grimshaw, my co-chair, who is behind the scenes, is our YouTube superstar today. So Roger will be sharing and will be interacting with you all who are with us on live stream. So you can use the chat facility on YouTube as well, because Roger will be feeding in questions and comments as well. So we built this huge community, right? Because the London ACEs Hub is this, we are a community. We are a network of survivors of trauma and ACEs, adverse childhood experiences. And we are a collective of multidisciplinary professionals. So we believe in this coming together. And that's why it's so nice to have all of you here with us. Today is our second Racial Justice Open Conversation. We will have more during the year, and we will have more webinars covering all adverse childhood experiences as well. So at the end of this webinar, you will receive a feedback form. So do fill in and share with us any suggestions of topics you would like us to cover. Because again, this is about building community, right? So we all appreciate you to be here with us, building this network. And it is about coming together to make London a truly trauma-informed and ACE-aware city. So thanks everybody, and I give a big, big hug from all of us from the London ACEs Hub. And now I will turn my picture off because I will be on the background as well. Enjoy everybody, have a lovely, lovely time.
Wonderful, Tiane, thank you very much for that welcome. So turning our attention to our special guest this evening, and the format that we're going to take for the session is that we will have a conversation among the four of us for about 15 to 20 minutes, exploring in our understanding in the topic of that. And that will be led by Jonathan and Lucy. And Koya and I will ask questions. If you also have a question as a participant, please put it in the chat and we'll pay attention to it. So without further ado, talking about the subject of ACEs and racism as an ACE, issues of health inequality, issues of limitations within medical education and the NHS in general. Let me welcome you, Lucy and Jonathan. Lucy, let's just ask you to do a very brief, very 1 minute kind of introduction about yourself, and then I'll come to you, Jonathan.
Thank you very much, Mpume. Thank you, Koya. Thank you, Jonathan. Thank you, Tiane. My name's Lucy Carter. I'm a GP in Hackney and have been a GP for 16 years now, but I've been qualified for a lot longer than that. And I'm a Yorkshire woman. I'm an African, and I have a story to tell, I think, tonight, and I'm really grateful. Thank you so much for inviting me back. I'm sorry I wasn't able to be at the previous webinar, but I'm really, really happy to be here tonight, and hopefully I can learn something from you all. Thank you so much.
Great. Thank you. Jonathan?
Hello, thanks, Mpume. Lovely to be with you all again. I'm a GP in Hackney, and I have been for about 20 years now. So I've been a GP to the same group of patients for that whole time. So my experience that I bring to this is seeing people over over many, many years and seeing how their circumstances affects their health. I'm also an educator and a member of the London ACEs hub because of my sort of interest in ACEs, which has been sort of pretty deep for the last 5 years. And finally meeting up with you, it's really brought racism into my thinking about ACEs and about health as well. So I'm very grateful for all of you and your diverse knowledge and experiences, and that's why I'm here.
Okay, great. So I'll actually start with you then, Jonathon. I'm interested to hear how you come to the whole subject of ACEs and the things we talk about, trauma-informed practice. But I'm keen to understand how you have made the connection between ACEs and racism, racialization, and the whole language around that. And especially that it is an uncomfortable topic for people from the majority white ethnic group to be at the forefront of having the discussion around ethnicity. And just the mention of a white ethnicity is difficult for some people to hear. So how have you come to it?
So yeah, I'm really glad you brought up discomfort. I think that's where I began, actually. There are some patients that GPs find really challenging, that make the doctors themselves feel uncomfortable. I can see that Lucy's nodding, and if there are any GPs in the audience, they'll recognize this. But patients also will recognize that sometimes doctors look uncomfortable in their presence. And I remember vividly now, about 10 years ago, a woman walking into my consulting room. She was about 6 foot tall, black, 140 kilos. She'd had an bariatric surgery which hadn't been successful. She had a huge stick, almost like a staff, covered in silver lame. And she walked up to me, loomed over me, banged the stick on the floor and said, "I need a doctor who can look comfortable in my presence."
Wow.
And I looked at her and I looked her in the eye and I smiled and stood up to greet her and said, "I think I can do that for you." And we've been friends ever since. But it was so powerful on so many levels, because she, like a lot of people who've experienced trauma, is extremely sensitive to how other people behave in her presence. And more sensitive than I or most doctors might be aware of. You know, they're always looking for signs that you are disrespecting them or not trusting them or not believing them, or not going to treat them properly or are not interested in what they have to say. And I often think about our first meeting then, because there's so much in that about the way that doctors, you know, for example, a white doctor might respond to a patient who's black, who's used to having poor care. And it turned out later on that I discovered her own history of trauma, and then the illnesses that she's developed in the time that I've known her that stem from that. And so that's, you know, you've just kind of created the situation now in Mpume where you've brought to mind this amazing meeting. And that's, yeah, that was 10 years ago. And what I'm learning now is still informing that meeting.
There are three things that you've mentioned there, which I've heard, which is the issue of a patient walking in frustrated with the system and the service. You've mentioned the issue of ACEs coming in. And then this evening, we're connecting the ACEs to race. So I get a sense that there's a developing awareness around the link between illness, poor health, and ACEs. If you could say a little bit more about that, please, John.
Yeah, absolutely. So the background for people in the audience is that the ACEs stand for Adverse Childhood Experiences, and there was a study in the 1980s that looked at how many categories of adverse childhood experiences people had and how that added to their risk of developing certain diseases later on in life. And what they showed was that people who've had, for example, 4 or more categories of adverse childhood experience have 3 to 4 times the risk of developing diabetes or heart disease or cancer. so that your experiences aren't just something that you could put in a box marked experiences or sociology or upbringing. It's firmly within the realm and the interests and the concerns of doctors. So for years, I think doctors have said, look, our job is to deal with disease. That's all sociology. That's somebody else's business. That's not my business. But now we can't avoid the fact that where the way people live their lives, what they experience, what happens when they're growing up, contributes to their risk of illness later on. And I have many Black patients who I look after, and quite a lot of the women I know, wear wigs and have problems with their hair, and that conditions like lupus and psoriasis cause hair loss. And it wasn't until very recently that I was prompted to try and explore the link between trauma and lupus, or trauma and psoriasis, and it more than triples your risk of developing these serious autoimmune conditions. And I thought, most of these women are Black. Like, what's going on here? And trauma, it's the threat response. It's what happens to your body when it feels threatened. And then I invited some of my receptionists to talk about growing up in Hackney in the 80s, and they grew up feeling constantly threatened, whether it was by police or by gangs or by racists. That constant feeling of threat and disrespect is traumatic. And even if it isn't one major thing, the fact that it's always there cannot but help change the way your immune system and your autoimmune system functions as you grow up. And yet it's never been part of my medical education, and it's not until recently it's been part of the conversations I've had with patients.
Yeah. And before I leave you to go to Lucy, my favorite expression from the first webinar we had was when you mentioned it's not just biology, it's also the biography. Can you just fill that one in for everybody, please?
Yeah, I think I described it before that, doctors, like the joke about the drunk who's looking for his keys under the lamppost because that's where the light is. Doctors look for reasons to explain illness where the biology is, because that's what they've been taught. And there's another lamppost shining over there on biography, people's stories of immigration, people's stories of development, the lives they've led, experiences they've had. You've now got to bring these two lights together. They're not separate. Nature is in a perpetual dance with nurture. The two things cannot be separated.
Great. Thank you, Jonathon. Lucy, let me come to you. If you could just tell us how you come to this work, your interest in that, and I'm also interested in hearing your own experience around, access to care, issues around health outcomes, that sort of thing. How has the journey been for you?
Thank you so much, Mpume. I have to say that I can really relate to the issues that Jonathon's receptionists talked about with him when they talk about experiencing difficulties growing up in Hackney in the 70s and 80s. I come to this I'm going to talk about my personal experience, because I am a woman of colour. I am an African, and I've grown up in Yorkshire in the 70s. And for me, I realised, just listening to what Jonathon's been saying, that I also experienced trauma from racism. And I really haven't been able to speak out about it until very recently. I've been called everything under the sun as a child, and a child who has to experience that or witness that against their mother, it feels very, very difficult, and you can't protect them, you can't protect yourself, and you don't know what it means. But I'm interested because I found a quote by Toni Morrison, who talked about, she says, "No one ever talks about the moment that you found out that you were white, or the moment that you found out you were Black. And when you do, that's a profound revelation. And when I realized I was different, that it was my skin color that was a problem, my body was a problem, the color, I suddenly didn't know what to do with it, but I realized that I was powerless to do anything about it as a child. In fact, I felt powerless to do anything about it for a very long time, until recently. But I realized that working with people who have trauma, and I work not only as a GP, but I work with people who have addictions within my GP practice. I work with people who have mental health problems, all sorts of mental health problems, and that's my speciality, I suppose, within my job as a GP, as well as I am a medical educator. So, you know, I am really faced with people who are living trauma and are embodiment of trauma every day. And particularly, I think about mental health, and I think about those patients who I've seen and witnessed as a medical student. My first experience of being a medical student in psychiatry was seeing a big man who was Black, who was pinned down by 6 nurses because he was very psychotic, he was very unwell. But that was a very traumatic experience for him. It was a very traumatic experience for me. And that, you know, colored my view of what psychiatry was. And I thought this was the worst thing that anyone could do to a person, is to do that. And I, for a very long time, really struggled with psychiatry and didn't understand why I was seeing so many men, Black men, in these wards in hospitals who had a diagnosis of serious mental illness. And I have really struggled with that until I thought about, well, there must be something that is causing them to be there. And it's not them, it's my perception, perhaps other people's perception of them being a problem because of the color of their skin, because they are seen as a threat, as aggressive. It's not true, but that is a perception that I've come to realize that other people feel that, and they really, it's a visceral thing. And these young men in particular are ending up in trouble with the police, are experiencing symptoms of psychosis, and are ending up on the wards and are experiencing mental health problems and not experiencing good service necessarily from psychiatry. So that is really where my experience of trauma and realizing that race was an issue. My other experience that I just want to share with you today was when I think about from a medical education point of view. I've been working with Queen Mary University, and I'm really pleased to have worked with them for a number of years. And I've run a course called Medicine Society where graduate entries come to the practice. And we did different themes every 2 weeks, and I had to recruit patients. And I realized I recruited lots of patients who were Black. And I realized they said to me that the reason that they worked with me, they wanted to share their story that they've never had the opportunity to do before, because no one's ever asked them what's going on with their lives. But you, Dr. Carter, I identify with you. I am proud of you, because finally I am seeing a mirror of somebody who looks a bit like me. And that's a huge responsibility for me working in Hackney, but I'm pleased to be there, and I'm very grateful for the work that I do and for the patients to share their stories with me. But I feel also very worried that up until they were sharing their stories and their traumas, they weren't able to express themselves. And I realized that with one particular patient who has had so much difficulty, had serious addictions, but could not even begin to voice his traumas of racism and of other things until he said, it's because you are Black, and it's because I needed somebody who I could trust. And it's really sort of brought home the ACEs, the adverse childhood experiences that those patients have suffered. And what can I do to make this situation better? I need to learn myself much more about it. I've realized I've been practicing it without naming it as trauma-informed care. So, you know, I realized that I need to kind of continue this journey and take this journey into the medical education field. So there's lots going on there, Mpume. Lots going on. Thank you for asking.
Lucy, I'm especially aware of the question of access and access to the right kind of care. Could you say a little bit more around that? Because I certainly, as a patient and being the African man that I am, when I'm approaching one of these establishments, I am conscious of the fact that I don't look like everybody else.
Yeah. And I have seen the problem of access. I am thinking of a situation where, and this will be familiar for those of you who are GPs out there, and not only in GP, but, you know, a young man in a hoodie, happens to be Black, is agitated and comes to reception And what he's getting is a barrier to say, no, you are a problem, you are aggressive, and I'm not going to let you in to access the care that you need. And so, but I, with my trauma-informed voice in my head, realized that I've seen this man before. I know the stories that are going on behind it, and I have a duty to make sure that I set a good example, and I listen to him, and I take him to one side with a colleague and say, look, it's okay, we are here to listen to you, and let's hear your story. Let me give you access, because you need help, and we are here as GPs to provide that help. I'm not here to judge you. I hear that you're distressed. That is what I'm hearing, and what I'm not hearing, because other staff are not hearing about the distress, they're just hearing aggression, and therefore the shutters come down. And this happens all the time. They make a judgment on your appearance, whether it's in A&E, whether it's in the GP practice. And if it's not about that, it's about, you know, not giving the pain relief that they need, because you're seen as a drug seeker because you have a diagnosis of sickle cell disease. You know, you are not given pain relief when you're crying out and you're in labor. And, you know, and then the outcomes for women who are of color, women who are Black, are 4 times more likely to die. We know this from the Embrace study from 2016, 2018. We know that women of color, Black women and Asian women, are dying are more likely to die in pregnancy than white women.
Let me come to you and ask the same question. Koya, I don't want to crowd you out here, but
literally what I want to hear. So it's great. Yeah, go for it.
Koya, and just Jonathon, and I'm asking you to come in. Koya and I have had a previous event where we draw the conclusion, and some of the NHS specialists that are here are not going to be happy with our observation. But what we said between us and others is that the whole birth process, the whole perinatal process, is to Black women what the police are to Black men. You know, so we don't have the statistics, but if people were to ask, we would be able to do that. This whole issue of outcomes. So, do you want to say a little bit more around the issue of outcomes, Jonathon, or Koya, or Lucy, if you want to come back in? Just what are the outcomes like for us people who are not? So it's Black and brown bodies. What's the experience been like?
Well, I can speak. I can speak from lived experience. That it's not been a good. Well, the outcomes have been good, but the process to get to the good outcomes was absolutely atrocious. And that is something that I hear, just not from even from my own experience. I hear it from other Black women as well, of all different ages as well. It's not necessarily, you know, there's no discrimination there in the age, but definitely in the color of your skin, the care that you get is different. So yeah, don't know where you want to go with that, Jonathon. Where next? How do you? Yeah, you're sharing on that.
Yeah, I think it's really important. I'm so glad you answered the question first, Koya, because what we know about experiences of care in the NHS is that people of color are asked less frequently, so they're not asked as much. They're more reluctant to answer because, I mean, people are quite often afraid of giving feedback because they think they'll get in trouble, or they'll be marked out as a troublemaker. So the next time that they go back, it'll be even worse.
Yeah.
So we know that the evidence we have, for example, in experiences of cancer care, that people of color routinely mark it as worse, you know, significantly worse than people who are white. But there's a real problem here is that we really don't know what it is, because the research isn't there. People are afraid. We're not asking them enough. There's got to be a lot more conversations with this, and we need to kind of fix that.
I think about cancer care, and I think about the aftercare, and I remember reading about women who've had breast cancer who are Black women, and how, you know, it seems like a very simple thing, but when they were offered prosthetics for the mastectomy that they'd had, they were offered a prosthetic that was white. Now, why would you do that? you know, or you have, you know, you're offered for lymphedema, you're offered a dressing to squeeze your arm. And again, it wasn't in the color of your skin, or tights that are not in the color of your skin. And so, you know, you're basically, the NHS is saying, yeah, we'll give you something, but it doesn't fit you, but that's okay. We'll give you a wig, but we won't make it so that it looks like you. We'll put a wig for a person who is Caucasian, who is white. And that's not right. So what you know, and that seems a very small thing. And why, you know, some people might say, well, why are you focusing on that? Well, I think that just is the superficial level. If that is happening, what else is going on that you're not offering women? Are they not presenting quickly enough when they have symptoms of breast cancer? I certainly think that's the truth. That's the truth in East London from the studies that we've worked on with the Homerton breast surgeon. You know, they're presenting with more aggressive breast cancer. You know, and then you offer them aftercare that is inappropriate, that's not culturally sensitive. That is unacceptable. You know, that if a white person was offered a black hair, an afro wig, after losing their hair from chemotherapy, there'd be an absolute outrage.
Yeah, it'd be great.
Sorry, you know, I apologize to those who know me, who are participants, that, you know, but actually it's the simple things. And then we take about, you know, Jonathon talks about the lack of involvement and fear. Well, people aren't being asked to do research. There are not enough people who are Black, who are Asian, who are taking part in studies, who are doing the research, who are very suspicious of research, you know, and maybe they are understanding their history more than I was aware until very recently. Well, completely understand why they might not trust scientists sometimes when things that, you know, big stories from America, Tuskegee syphilis, for example, you know, why would you trust the scientists when they've done things to your body in the past, not that long ago?
Yeah.
So, but at the same time, we need people to be involved because we need the truth to be out there about what's going on.
Yeah.
Can I come back to you, Lucy, on the...
Let me just do this. Let me just do this and you'll come in. I'm inviting others because we're in the polylog phase. I'm inviting comments on the chat. I'm inviting questions. I'm inviting all that from everybody. Let's just get in there now that we've heard a little bit more about Jonathon and Lucy and their experience. Yeah, go, John.
I was going to say that so some people define trauma as something that leaves you with the sense of not being worthy of love or attention or respect or being seen or being heard, which I think is really powerful.
Yes.
And I don't think I'd even thought about it, but when you prescribe lymphedema dressings, they come in flesh color or black, which isn't a black skin color, it's just like black. But flesh color is just one color. And you can guess what color it is. And but if you think that, you know, if you agree with the idea that trauma is, you know, this sense of being unworthy or not good enough or not being seen and not being heard, then this is like these little things must get to you, just like the accumulation of all these little, okay, so all right, I just have, that's okay, that's what I get kind of thing. It feeds the trauma, I think.
Well, it really does. And Koya, I don't know what you think about this, but for I, you know, every day, every week, every year, there are constantly, I've grown up with not fitting. I've grown up with, you know, it seems, you know, makeup or, you know, seeing things in the NHS that just aren't right, and not being able to voice it and say, come on, you need to do better. Koya, what do you think? You know?
Yeah, I was just going to say that as well. To add to that is, it starts from when you're really young. So that not fitting and not feeling worthy, it starts from, you know, from you're from you're born. Obviously, we're going through it as a woman, that you have your child, that you, before the child's even born, you're already with that because you've experienced it. Then it's with the child. Once the child is in your stomach, once the child is born, school, nursery, all of these places, it's just every day. You're, you know, out on the street, a little child, black, you're getting these all the time, every time, all the time. So it's like, it's going to have an effect. That feeling of not feeling worthy, not feeling good enough, you know, it becomes ingrained in a way. Yeah, it becomes ingrained. And then that's why we then have situations with people with psychological issues with the body. Dis-ease in, they say dis-ease in the mind called disease in the body. These are things that it's a real thing, and this is what we're experiencing, what we're seeing right now, you know. Yeah, if it's not happening.
Yeah. Can I just bring in just another issue that I've just thought about? You know, I think about, and we'll talk about it a bit more, about skin issues in Black people, and this complete lack of education around skin issues. And I've been on webinars with American dermatologists who are women of color, and talking about things like Jonathan mentioned, like lupus and the hair issues and the hair loss, which is, you know, it was just called traction alopecia and that was it. And it's because it's our fault because we put braids in and that's the end of it. Well, it's not that. There's bigger issues going on in terms of hair loss in Black women, and we need to be teaching our medical students about this. It is unacceptable to say that, you know, it's just hair loss and it's your fault, it's your braids, that's it, because it's your culture, your fault. Well, it's not. It's because you're not recognizing that actually there is a scientific reason underlying it, or there's a disease underlying it that might be down to trauma, like lupus, for example. Lupus is a big cause of these things, but not the only one. But even I take it at a more basic level. As a person who's suffered from skin conditions ever since they were very little, maybe it's an expression of trauma in itself, and I do believe it was, that nobody could deal with it. And yet I'm seeing patients and they're going, they don't know what to do with their eczema, for example. And I'm the one who's going, well, this is my experience. Put the medical stuff out the window. This is what I think you should do. I know where you go and buy your creams. I know what might work for you, because I understand what you might need. Your skin is different, and I can vouch for that because mine is very similar. And I hope you understand, and they do appreciate that, and they do recognize that, and their skin does get better, you know. So I think it's duty bound on everyone to educate themselves better about it. What seems like a very simple thing, but skin conditions are traumatic. They affect people's sleep. Children are very small if they have severe eczema. You know, this matters. And if a child can get better from eczema or psoriasis or any other skin condition, then they will feel more confident in themselves. But what you're doing is you're holding them back. You're saying you just have to live with it. You just have to live with the hair loss. Well, I'm sorry, I don't really accept that.
Yeah.
In the US, Doctor, I see you, Koya, and I'll come to you, and then we've got to move to the next session. Dr. Kamara Jones, as I said in the last session, has given what I think is one of the most succinct definitions of racism. And Jonathan, if you remember, we were talking about helping people with the vocabulary. There's nothing wrong with race. There's everything wrong with racism. There was the issue of we can do racist things, and so there's a conversation to be had, and I think we'll post some stuff on the website around notions of language and how we call things. And oh yeah, and I was really pleased. Koya, I don't know if you noticed that government has put out a guide. Maybe you shared it with us, Jonathan. Around the fact that the BAME word is this derogatory term that really just turned it over. I got angry from that word. They finally put out a guide which says, don't refer to us like that. If anybody wants to talk to me, I am as through a Zimbabwean man as you're going to get. You know, if the worst you can call me is a man of African descent, and I'm very comfortable within that. But that's my issue. Just going back to what Dr. Kamara Jones talks about. She says, she defines racism as four things. Number one, she says it is a system. And what the system does is it disadvantages one group of people on the basis of how society sees them. So the notion of being Black is non-existent. It's not biological. It's just how we have been referred to. And in another event, somebody traced the history of how we came to be making distinctions like that, and found that it starts out with the Spanish going after Jews and talking about bad blood.
Yes.
So that's how far back it goes, to about the 17th century, for those that are interested. So the first thing is, it's a system that disadvantages some people who are Black on the basis of their color, and their color is determined by white society says. And then it advantages other people again on the basis of their skin color, which we call white, Caucasian, and so forth. So first thing is the system. Second thing is disadvantaging one group. And third thing is advantaging another group. And finally, and this is the powerful thing about it, it saps the human resources of strength and power. Here we are spending an evening talking about something that is notional. It doesn't, it shouldn't exist, but it does. I've got to watch what I say. It shouldn't exist, but it does. So that's really something we need to take into account. This is what is going on. But I just want to press the three of you with this one question, and then we move to the next point. Are we making race an issue? Is it really an issue? Is race an ace for sure, or are we just trying to put it upon other people?
Oh, it's definitely an issue. People are affected by it. Racism. Race is being the race that you are. Well, it's a social construct. It was something that was created in order to dehumanize people, so you can use them in the way that you wanted to use them. Then obviously, then that follow-ons from that is colonization, and all of those things, and how that plays out. So racism is definitely, it's not something that we're putting out there. It's out there and it's happening, and it needs to be something that we look at and try to change it so that it's not happening, basically, that people are not treated differently or less than because of the color of their skin, and look at who they are, what they do, how they do it. How can we look after people better? What is needed, you know?
Yeah. Can I just read some of the comments that have come in the chat? Matipa Katsukunya, healthcare systems do appear to perpetuate these microaggressions, and I hope people understand what microaggressions are of people of color when they're raised. It feels as if you're speaking out of turn, and then you're silenced, which is lethal. Helen Newitt says wigs, patches, tights, etc. being depersonalized as the 10-year plan strives to move towards personalization. And Ikra says, what Lucy says really resonates. As a medical student, I've noticed how presentation, especially of skin issues, is only Caucasians. Looks completely different on different skins, and yet we aren't taught to recognize these different presentations. Medical school continues to fail to diversify, and it is very disappointing. If we can pick up that point when we come to say, what can we do about it? Because I'm really keen on talking about the issues of what is happening in medical education and medical schools. Before we move to the next one, anything that you guys feel really keen to say about this notion of we're facing the facts around racism as an ace, and how we evidence it within health inequalities and primary care?
Surely the first thing we have to do is have the conversation. We have to speak about it first, and we have to speak to as many people as possible in order to get the message across, whether it's London ACEs Hub, whether it's talking about people at RCGP, Royal College of General Practitioners, whether even, you know, we should be, and I know that Simon Stevens is keen and has had discussions around the issue of in health inequalities and of race. You know, I'd like to have a conversation with him, you know, because he's the one who's setting the 10-year plan, for example. These things are really important. You know, that's what I personally think. Racism is one of many traumas that patients are suffering from. And we've talked, and we continue to talk, and rightly so, about the other ACEs that people have experienced. But this is something that has been unsaid until recently. Although I realise there are lots of papers that have been written about since at least the 80s on this, but no one has talked to me about it, and I'm in medical education. So, you know, it is something that we need to bring to the forefront. It's time.
Yeah, back to that point that Jonathan made, very important point for me. This is for me, not for everybody else. Biology and biography, absolutely essential that we keep those two things together. Let me move us along then to start to ask the question. So we've faced the facts about what the problem is. What's the solution? how do we fix this? And in discussing the issue of fixing it, I'd like for us to look around again. What is it that if I am a GP, which is the farthest thing that I ever can be, what can I do to start becoming aware and to start operating in this way? And in our practice, whether we're primary care or wherever we are, what does that look like?
So, yeah, Mpume, there's also some questions in the Q&A which we might want to come to as well.
Mm-hmm.
I mean, Lucy and I have discussed this, and you just covered it. I think whenever you think race, think racism. Like whenever race or racial differences pops into your head as a thought, you know, you need to catch it, stop it in its tracks and think, how is racism operating here? Is the question you should be asking of race and questions of race, which we know to be a you know, like a social construct. But and if you ask this question seriously, then you will begin to learn, and that also involves speaking to people who've experienced it. So it's a bit like my example at the beginning of the COVID pandemic and the first wave, where people have, you know, the first doctors to die were Somalian descent. And so people thought, well, maybe it's a Somalian thing.
Yeah.
And then Asian, you know, GPs of Pakistani and Indian descent died. And oh, well, maybe, you know, it's to do with that. And then people from Bangladesh in Tower Hamlets were dying. And we thought, oh, maybe it's that. And then Caribbean families in Hackney were dying. Well, maybe it's a Caribbean thing. Maybe people die from COVID because of how much melanin they've got in their skin. Like, what an absurd, you know, hypothesis this is. Perhaps, you know, people of color are more exposed. Perhaps they're working in frontline positions in the NHS who aren't being prioritized for PPE. Perhaps they're doing jobs that involve lots of public facing contact. Perhaps they're getting to work using 3 buses and a train.
Yeah.
Perhaps they're living in an overcrowded house with other generations because they're also caring for people, their parents and their children and grandparents maybe. You know, we need to ask this question. If you're thinking race, think racism. Ask the question, how is racism operating here? What disadvantages or what are people up against? And it's a real shift of change, a change in pace and thinking for doctors.
Yeah, I would 100% agree with that. 100% agree. I just think about, you know, when it moved from the different, as you've described, the different communities, whether you're Somalian, whether you're Southeast Asian, Bangladeshi, you know, it really, we have to ask ourselves, what is going on that makes these people, why are these people dying? Why are the bus drivers dying in such large numbers? It's about being patient, it's about being people facing, it's about, you know, the nurses, you know, I just think about the nurses and the other staff that have died at the Homerton, you know, patient facing. Our colleague, Mr. Chowdhury, has died. He was a urologist, and you know, deeply moving. In the 2 months before he died, he actually put out a statement to say, you know, please give us PPE, proper PPE, because we're going to suffer from COVID-19. And unfortunately and tragically, he and other staff have died as a result, I think, of that. You know, so it's about being exposure, and it's about suffering, it's about poverty, it's about, you know, deprivation, and it's about, well, how is it that these people are deprived, are in poverty, are struggling, are doing 3 jobs just to make ends meet? What is that about? You know, and I agree, it's about, you know, one of the things is about racism.
Yeah.
I wanna, sorry.
Go, Koya.
Yeah, there's 2 questions in the question and answer. You know, so I just wanted to put that out there. How do we get better at challenging ACEs and bringing in the racial perspectives, as ACEs are often viewed very Eurocentrically? It's tiring to bring in a different perspective. There is a lack of acknowledgement of ACEs with regards to the racial experience. I just want your ideas, thoughts, anything around that for any of you.
Well, I mean, I would be, you know, just I would be thinking about talking with my colleagues who work for NAFSIAT, for example, a psychotherapy organisation in North London, because they've really helped me think about cultural competency. And I think that's, where we need to start, when we're thinking about ACEs and racism. They're a fantastic organisation and they've got a lot to bring to bear here. And they're quite a small organisation, but they've got a lot of experience, So I personally would be looking to them to help me help others in thinking about ACEs and racial trauma, as well as yourselves, of course.
Yeah, definitely.
I don't know what you think, Jonathan.
Yeah, I mean, both Lucy, both of us are involved in medical education, and what's completely changed since we were students is how much patients are active partners in education these days. Like, they were objects of curiosity. They were wheeled on stage, and the students would look at the patient while the doctor prodded them and poked them and showed off their rash or whatever, but they weren't asked to speak or tell their story or give their side of the experience. And medical education's unrecognizable now compared to when we were training. The amount of that we're involving expert patients, we're getting students to take stories about their experiences, both of healthcare, but also of growing up. One of the commonest questions my students ask patients these days is, what have you experienced you could tell me about that would make me a better doctor? Like, they're interested in patients' experiences of healthcare and they want to do it better. So they invite patients to tell them the stuff that maybe they're too afraid to say in hospital. The students are far more diverse than they've ever been before. So there's a real...
I'll pick you up on that, Jonathan, sorry.
Yeah.
I'm going to pick you up on that because you're absolutely right that, the NHS is diverse, the medical student body generally is more diverse. But what I'm not seeing in medical school is I'm not seeing young Black men, Caribbean men from Hackney, from the schools in Hackney, coming into medical school. And I just say Hackney because that's where I'm working at the moment and that's what I'm experiencing. I don't see many people who look like me. There are, and there's certainly more now than there were when I started 25 years or however long ago, I won't want to say, and I really do wonder what is going on about in terms of access to education, medical education, because I want to see a real range. I agree with you that there is a diversity and it's fantastic and the students are brilliant. I am proud of all of them. But I still want to, see more self-identification. I want to see more people who look like me. I want to see more young Black men who look like, like Stormzy, tall, big, Black, local, who are clever, who can work with the community, who can represent the community, who can understand it and do a really, really good job, And I'm not seeing enough of that. And I know my colleague, Dami Harry, who's a urology surgeon, who's from America, but also from Zimbabwe, he will also recognize that, and I want to know why we're not having more. So one of the solutions will be to look at how our access to higher education, because access to higher education for Black people is not good enough.
Yeah.
Sorry to interrupt you, Jonathan.
Yeah. That's fine. Let's do this. There's another set of questions that has come through, and we're going to read those at the same time and then try and answer them as we go. But in the meantime, Tiane, if you could please find Dr. Rofique Ali for me, because I'd also had a brief chat with him if he's available to contribute to what we're talking about. And while you're there, Tiane, I'm just loading you with stuff. If you could also find out from Roger if there are any questions that are coming out on the YouTube thread, just in case we don't miss anybody. But let me just read these questions that are that are in front of us. So, hi Derek, why do you think so many Black people are dying from COVID in the UK, but it's not killing Black and brown people around the world? That's the one question from Derek. I'm going to say this name wrong, and I apologize. Bigona. The fact that an individual is consistently treated unfairly because of the color of their skin across their lifespan completely shifts how they perceive the world around them. Racism is real and it needs to be considered. And then Lindsay Hamilton says how to get doctors to be aware of ACEs and racism issues, including their own attitudes. And then there's a couple more questions that I'll come to, but let's have a stab at those three for now.
Wow, that's quite lots of questions. That's really, really
pressure
good.
or nothing, you know.
That's it. Yeah. Before we speak, Rofique, hi and welcome. If you want to unmute yourself, what's the situation like in Tower Hamlets?
No, I think, I mean, it's really nice hearing everybody talk, actually, and we're not far from Hackney, so a lot of the experiences are shared. So I think there's similar sort of picture. And I mean, I would share the thoughts that are expressed by the panelists here. I was quite interested in one question you said, what are the solutions actually? So to this, and we have, so I work in a practice where again, where a lot of the doctors have been here for a long time. And we also have a highly personalized list system. So this is where you, as a doctor, as a GP, you see the patient, the family, and you continue to deal with their problems, their referrals, medication, everything. So you get to see over a long period of time the impact of the environment, their social circumstances on their health, and you get to build a really good picture of this, which I feel gets you to understand that, have a deep empathy on the adverse childhood events, which allows you to develop and work with the patient on solutions for them that are incorporate some of these empathic feelings. So things that you can't describe actually. So just to give you an example, I mean, I've got a patient who I've known him for nearly, I think, 8 years now, and had sort of abusive childhood experiences, and then got into drugs. So he was taking heroin and smoking cocaine, got into trouble with the police and stuff. And there's one day I sort of met him in the waiting room. He was shouting at reception, and reception called me, and sort of I approached him and I said, he just joined our practice. He's moved from another borough. So I said to him, look, you know, I can see you're distressed, but I am your doctor and we have a personalized list here, and I'm going to try and help you. But I can understand there's lots of other things going on, but you need to give me the time. Let me help you and navigate this problem. So we met, and I sort of described the way we work, and that, you know, I may not have the solution, but over time I'm going to learn and understand your journey, understand your health. And what was interesting is a couple of last year actually, he'd gotten in trouble with the police. I helped him out with writing letters for courts, housing problems. He'd got in trouble with the education system, financial problems. There are lots of things that were happening in his life that were not health, you know, they were not health issues, but I was involved in that part of care. And then last year he came to see me actually. I hadn't seen him for a year, and he'd said he'd basically given up taking drugs for about 18 months. He'd been to rehab, and he was doing voluntary work. And basically, there was a chance that he might get a job, and he needed a reference. So he was asking me for a reference. So that's an 8-year journey, actually. Very interestingly, the relationship that we established, it wasn't easy. It was very challenging at times in terms of resources, the time required to sit there, understand the journey, understand his life. But we've got there, and he's working, and it's fantastic. Actually, he's actually contributed to the health service during COVID. And I think part of that story is describing really this, what solution, which is that some of these adverse childhood events do require a long-term relationship with the patient that will take years sometimes to get to that point. And often at the beginning you can't see it. You can't see where this is going to go. It doesn't always turn out to be beneficial, but I know that long-term relationships can help actually. And I'm sure Lucy and Jonathan will sort of be able to relay that as well.
Yeah, sure. Rofique, thank you very much for that contribution. I'm really fascinated by the idea of a relationship-based approach to addressing these things and understanding the wider holistic context for that. And so thank you for that. Let me just press Jonathan on one question, Lucy on a second question, then we'll move to the next lot.
Yeah,
Jonathan, there's a question here which was asked: how do we get doctors to be ACE aware and racism issues, including their attitudes? If you can just answer that one very, very quickly for me. Lucy, there's a question that was asked by Begoni. The fact that an individual is consistently treated unfairly because of the color of their skin across their lifespan completely shifts how they perceive the world around them. Racism is real; it needs to be considered. If you could just say a line each on that, and then we'll go to the next lot of questions.
So yeah, so the question of how to make GPs and more ACE aware. So you take a top-down and a bottom-up approach. So the bottom-up approach is talking about it with medical students, both teaching and modeling good behavior. So they come into your practice to watch you work. And then if they see you having these kinds of conversations, and then they develop the confidence to have these sorts of conversations where they are curious about people's experiences, they will see that that's how medicine is done. It's not like a separate course or something. That's just part of normal medicine. So that would be the bottom-up approach, and the top-down would be educating educators. So it becomes part of the consciousness and the way of thinking for GPs who are training GPs, or educators who are training medical students. And we're working to do both of those things.
Yeah.
And we do a lot of reflective practice. There's a question from Kate White about how to, where's the space for white students to examine their own privilege? The privilege of being white is not having to think about racism.
Yeah.
To start with. So being able to think about how you can move effortlessly through different systems, or at least relatively compared to people of color, is really important.
Yeah.
And people need to feel safe. These are uncomfortable conversations.
Yes.
So you have a role as an educator to establish, set a, an environment where people feel safe to talk about uncomfortable things.
Yeah. Great. Thank you, Jonathan. Lucy?
I think the answer, I'm not sure it's a response to Bigona, I think is very similar to what Jonathan has said in the fact that we need to be educating ourselves as educators and also educating the medical students, because unless and also to share experiences if we feel comfortable with that. I think that's the other thing, Bigona, and that's why I'm here today. I hope that, by me sharing my story, it's only a little one, Rofique sharing his, Koya sharing hers, and Mpume sharing his, that other people who are white will start to understand the impact of racism on the body, on the person, on the health inequalities, and the message will percolate out. That's what I'm hoping. I think the fact is that we haven't been able to have enough of a voice in medical education. I don't think there's been voices elsewhere, which is great. There's been voices within the police. We talk about Leroy Logan. We talk about within films, etc. We're saying things. We've got the Black Panther movement. We've got lots of movement. We've got the Black Lives movement. But in medical education, we are only just starting this conversation on racism, and we need to have the conversation that talk about racism and sit with the discomfort. Really sit with it. and I need to hand that discomfort over to somebody else, because I've sat with it for a very long time, as a lot of us have, and now I just want to let other people share that. I'm not sure it quite answers your question, but I hope so in some way.
Yeah. Lucy, may I ask that you don't hand it over to someone, but that a few more people come and share it with you, because we still want you right at the forefront of what we're talking.
Yeah, sure, absolutely. Yeah, of course.
Yeah. Let me just, Koya, I can see you want to say something. Let me just pick up a couple more questions, and then we can carry on with solutions. So, and this one I think I'm going to ask you, Lucy, to respond to as well. Do Black males feel as if medical education is achievable for them? Society often makes Black males feel unworthy unless they are athletes or rappers. That's one. Then Jonathan, there's another question from an anonymous attendee which says, as a white medical student, what can I do during my studies and in my personal life to help tackle racism and the consequent inequalities in health? And yeah, I'm not going to be unfair with you with that one, Lucy, if you want to chime in on that one as well. And yeah, and then the last one is from Kauleza Mnaneni. Yeah, you need to have a tongue like mine to say that.
Yeah, that I was like, thank you. Love it.
That comes from my part of the world.
Wonderful.
Do the GPs have time to consider ACEs when they see the young people in the surgeries? They rush the consultations and have a few seconds to see patients. Could the race affect the management of Black children presenting with complex issues? Do they ever consider ACEs? I'll let you guys. Rofique, please feel free to chime in as well if there's one of those that you want to. And unfortunately, as much as I hate doing this to you guys, we're going to need to be more aware of the time. It's winding down.
Well, so if I can respond to Charlene's comment, do Black males feel as if medical education is achievable? Well, as far as I'm concerned, absolutely it is. My thoughts are that I need to get out into secondary schools, not just me, but we need to be, all of the people in medicine, GPs or hospital doctors, should be role models, should be going out there and reaching out and saying, you can do it, because look at me, I've done it. I have patients who are now 18, I've known them since they were 5, I'm very proud of them, and they probably will become a doctor. And one of the things is that, you know, it's about me modeling what they would like to be, to aspire to it. They can be done. You don't have to be the absolute top. What you do have to do is work hard. And I have great belief that people can work hard. It's whether other people believe that these young men can work hard and be consistently working hard and be supported, because there are disadvantages that they've already faced. And if we can make the playing field more level, then that's great. And I know there's lots of people in the Hackney community who are trying to do that at a secondary school level. So, you know, yes, you can aspire to be a great athlete, you can aspire to be a great rapper, you can be Stormzy, you can be anything that you want to be, as long as you believe it and other people believe in it. No one believed, except for my mother, that I could be a doctor. And I listened to my mother, thankfully, and not to the school. But I think the schools are better now. But you still have to kind of push back and say, I can do this. So that's what I say to Charlene.
Great, thank you.
So quickly, for the white medical student, don't think you have to do it on your own. Find allies, find colleagues, find a mentor, check in with the London ACEs hub. There are lots of people that feel like you. I've taught hundreds and hundreds of medical students who often ask the same question. So network, get together with like-minded people, educate yourself, form a team, and then together we'll make a difference.
Great. And then to the three of you GPs, that question from Kauleza, I think for me it's essential. Do the GPs have time to consider ACEs when they see young people in surgeries? They rush the consultation and have a few seconds to see the patients. Could the race affect the management of Black children presenting with complex issues? Do they ever consider racism, ACEs and racism as an ACE?
Oh, Lucy, go ahead.
I only will say that I think GPs are so pressured with so many factors in a consultation. But any GP worth their salt, even if at the time they know that they've rushed the consultation, do have study groups, have colleagues, they can sit back and reflect with their colleagues, because we do talk to our colleagues, don't we, about the difficult conversation with the patient. Perhaps it didn't go quite as well as you would hoped. If a good GP can reflect on what's going on with their colleagues, they can then start to understand the ACEs and racism as part of it. They do need to check themselves and to think, could racism be a problem here? Could this be part of the issue? Are ACEs going on here? So we have to check ourselves. That would be what I'd say.
Okay, great.
I think I would say, I mean, if I go back a year, I hadn't even come across the term actually, ACE, and thanks to Jonathon and lots of other people, it's part of my language now. So it's something that I've been, as a GP, I've been able to construct, understand, and I'm still learning. So I'm still learning about the complexities of this in multiple different areas, including racism. And that's thanks to the work that's been going on in the background by a lot of people here and other people who are, I'm sure, listening to us. And I think as a result of that, I would say that the short answer is yes. I mean, I am considering. I think I could consider it more. So the spaces in terms of the language has been created, and I think that needs to be spread more so that other people understand. And I think, Jonathon, you really use this, the epistemic injustice concept, which is, so this idea that if you don't know it exists in terms of language, you can't address it. And so I think it is getting better, and I certainly, even in the last 6 months, I feel that if I see a patient and maybe I'm not getting to the bottom of a problem and it's difficult and challenging, I would consider ACE. And going forward, I think it's getting established into the education system. I'm an educator. I also train other educators within the practice and wider. And I feel that it's moving in the right direction. Maybe it needs to move faster. So I think the space is being created and the spaces are connecting with each other in the right way.
I have a presentation I do when I'm teaching GPs about this, and it says, it's called "These Patients Used to Do My Head In, How Trauma-Informed Care Has Made Me More Compassionate, More Resilient, and a Happier Doctor." And the way I sell this to doctors is that the patients you struggle with most of all, who you worry about most at night, who you kind of argue with and fight with, if you bring this into your practice, if you're ACE aware, if you understand the impact of trauma, then it does all of those things. It makes you more curious, more engaged, more compassionate, happier. It's genuinely changed my working life in a really positive way. I'm far less burned out than I used to be. People worried it'll take more time. Actually, it's a bit of time invested that saves you a lot of time later on.
Let me bring in a comment from Rohini. It says it's important we encourage them to continue that practice when they come into the workplace. Presumably, that's doctors taking the time to do that. And then the comment from Lizzie Lowenstein says, my friend Lizzie, and Lizzie is into the learning organization, so thank you for joining us for this one. As well as the inclusion in training for medics, the system itself does not allow addressing trauma in any form. E.g., 10-minute doctors meeting just does not allow any time of exploration and does not encourage people to open up in the foundational way. What can we do to change this system? And I see 2 more comments that have come in, but let's tackle those and we'll come back to it. Anybody wants to pick up either Rohini's point or about doctors doing that more often and being encouraged to do that, or Liz's point about how do we get doctors to be able to find time within the 10 minutes to do this, exploring trauma, that is, I suspect.
Do you want to go, Rofique? I mean, I take your point about continuity. You make a commitment to somebody who's used to being rejected and pushed away. That's part of the experience of trauma. If you meet a doctor who said, actually, I'm going to commit to you, we're going to have a relationship.
Yeah.
It's like, what? Nobody ever
Yes.
said that to me before.
No, exactly. And, you know, so I can say right at this moment, I have 0 heart sync patients because of, you know, so heart sync patients are patients that when a doctor sees them, you have a heart sync feeling because the problems that they're experiencing could be complex, and that's because, I mean, I've developed a way to number one, recognize that this patient has other issues that are not obviously health related, but also the fact that I can invest time from the very beginning, knowing that at some point the half an hour that they will take up in the middle of a busy clinic will turn into 5 minutes later on, where they will understand me actually. So what I see is the patients have empathy for me, where they can see that I'm, you know, maybe running late, or I won't have as much time with them. So we're working together to resolve issues. So definitely relationship aspect. So I guess one thing that the system needs to do is to ensure that maybe it is possible for doctors and healthcare professionals to maintain long-term relationships, which at the moment it seems to be fragmenting actually. And the other one is that that's one space that I think that could be facilitated. The other space is given more time, and we know that you know, areas that need more time don't usually have the time to deal with lots of these complex issues.
Yeah. I think I would second that. You know, in East London, we are all struggling for time. We're seeing so many of patients with ACEs, and perhaps racism as one of the ACEs, and complexity. And I'm 100% behind the idea of, you know, having a relationship with a patient that, you know, it's continuity. And at the moment, it has to be over the phone. But that's the way it has to be, and I will see them if I have to, but I do try and maintain that relationship over the phone, a check-in, you know, or they know the days that I work, so that they know they will phone in on those days, and I will take that call. And that means that you know, you can build a relationship over a number of years with them, and that hopefully there are good results at the end. And I have had good results you know, it's worth investing that half an hour. Run it, and I apologize to all the patients that I've run late, but that's because I'm trying to invest in what I need to hear the story. I can't interrupt this story right now. This is important. They need to tell it now. If they don't, they'll go away and do it again, and that's not. I have to let them do that. But you know, there needs to be an investment from top down into the more deprived areas of London, so that to give the GPs and other health professionals the time in which to do this.
That is echoed, I think, in the question or the statement that's been made by Bekona on the Q&A, which is asking a simple question at the beginning: how are you feeling today? Pause to listen to the patient. I think it's something as simple and as basic as that is important. There are a few more comments that I just need to read up. And then there's a question to come with it. So there's these comments again from Kauleza. I've witnessed this in my own child. From what Lucy is saying, GPs do not go back to the patients and admit that they got it wrong. I've observed racism manifesting as professional bias, where Black young mothers are treated differently. I wish as doctors, this can be addressed in educational settings with doctors. So again, as part of the doctor CPD, can we make it safe for them to acknowledge making mistakes? Because at the moment it feels a little bit more punitive. Margaret says Margaret Kieran says, apologize, says we introduced ACE awareness into my school, and it has really changed the way we view families we're working with. And then I'll come to Andrea's question in a minute, but let me just take the others of Margaret Kieran's observations. In my own private practice, I also use ACEs as an assessment tool. So the message, I think, is getting through that we are becoming more and more ACE aware. We just need to grow those opportunities and grow awareness in that. I know the time is gone, so let me take this question from Andrea Wright as the last one. I'll give you everyone a chance to close. When does the panel decide that ACEs is a factor in a person's presentation? What is the problem-solving approach to lead to suspect this?
Do you want me to? I can start. So, in my experience, the ACEs is what you're left with. You can have adverse childhood experiences and come through unscathed if you have enough support and protection in your life, and if the adverse childhood experiences aren't too severe. So not everybody who experiences adversity in childhood will have problems later on. That's really important. So history is not destiny. But for those people who you're seeing who have autoimmune conditions, chronic pain, chronic anxiety, most mental health conditions, especially things like OCD, eating disorders, psychotic illnesses, patients who have multiple overlapping conditions, irritable bowel syndrome, combined with an autoimmune disease, combined with a mental health diagnosis, you can be almost certain that they're behind this. You know, the causes behind the causes of these illness lies in adversity and a lack of protection and buffering and safety in their life. So that's the way I would look at it.
Great. Jonathon, thank you very much. We're down to the last 3 minutes now. So before we close, I just need to give everybody an opportunity to make one closing remark. We have been talking about the issue of racism as an ACE and how this plays out within the medical sphere, health provision and health education. So we haven't had enough time to talk about health education, but presumably that's going to be another topic for another discussion. But let me offer everybody a chance to just make your closing remarks. And I'm going to start with you, Lucy. Sorry to put you on the spot.
Well, I'd like to end with a really positive comment. I would say that in terms of, I'll talk about health education and medical education, that we are, as Kamara Jones has said, you know, we are convening anti-racist scholars and activists within our medical schools, not just at Queen Mary, but I'm very proud of Queen Mary, but across the country. Yeah. And if we start by doing this, then we can change the curriculum and we can change the outcomes for the patients.
Thank you. Rofique, anything that you want to?
Yeah, I mean, just as a GP, I'm still on the learning journey, actually, discovering ACE and how significant it is in the story of the patient. And you know, I will make mistakes by not recognizing it, and I will learn. And I think that hopefully that learning and integrating into systems and spaces is going to be something that's hopefully going to provide the solutions we need.
Yeah, John.
Yeah, I would also. I'm really hopeful. We're at the cutting edge here. So people worrying that we haven't got there yet. Like, we're on a journey and we're reaching out, and more people are joining us every day. Which is really encouraging, and it's really collaborative with patients as well. Like, this is probably the time in my career when I felt most aligned with the needs of patients, and that's really exciting. And I think we have to be humble. We're going to make mistakes along the way, and we have to, you know, just as, you know, I'm going to say, as a white person, will say things which I will be a bit racist sometimes, and I have to be called out on that. And we're going to make mistakes about ACEs along the way, but that's because we're learners, and have some humility. But these are really exciting times, and we're making progress all the time.
Great. Yeah, it's wonderful, and thank you, our panelists, for this. Thank you, everybody that joined in, and it's been great to be able to join in on this journey. Over to you, then, Koya, to bring us to a close.
Yeah, so we invite you all to support the Racial Justice Working Group's call to action. and promote the London ACEs work, and stay in touch by following our Eventbrite page and subscribing to the London ACEs Hub newsletter, which is called News for Action, on our website. You can find that on our website, which is at www.londonaceshub.org. Please complete the feedback. You'll be getting a feedback form that will be coming up. Please complete that for us. And yeah, just keep connecting the dots and spreading the seeds. We've got to end this. We've got to make this not happening. We've got to be in a different place, different space, different time, loving, learning from each other, encouraging, being, empowering, inspiring. Let's do this. We can do this all together to make the change that we need to make. So let's keep doing it. Keep doing the work. Power to you, people.